Good evening and a very warm welcome to all of you. And at the very outset, I thank Rajesh and his team at Mice Ideas and the Indian Oncology Foundation, and more so, Glenmark, for conceptualizing this program and bring it to
Sir,
fruition.
good evening.
Hi, good evening, Suman. It's indeed a great honor and a privilege to be with the so many accomplished oncologists out here, so many colleagues, and who are pioneers in the field of oncology and who are championing the cause of immunotherapies in oncology. We are today, as all of us would agree, at a very pivotal moment in medicine, especially in oncology, where the promise of immunotherapies we are realizing, and already from theory, this has gone to a very powerful and a robust modality of treatment alone in combination with chemo, with targeted, and many other things. Friends, we agree that for many, many years, there was a very bleak outcome for the advanced lung cancer patients, and there were limited treatment options. And of course, that was limiting the prognosis overall. But now we have already seen a dawn, and the sun is shining bright with the immunotherapies around. The paradigm of chemo and radiation alone has moved in advanced lung cancer, and we are harnessing the body's immunity to fight these cancers. Over the next 2 hours, we are going to witness some very great presentations around immunotherapies and in lung cancer, in gastric cancer, and the drug which is in discussion is tislelizumab and plus minus. Of course, they always piggyback only in certain situations where using these drugs alone. And without taking more time, I do trust that we would be better informed and take the message home how we can treat our patients better tomorrow morning. The first topic is tislelizumab in lung cancer, current evidence and future directions. And our speaker is Dr. Sumant Gupta. He's Director, Department of Medical Oncology, Metro Group of Hospitals, Faridabad. And the second talk is by Dr. Vineet Talwar. He would be speaking on next-gen immunotherapy, tislelizumab impact in esophageal cancer. Vineet is Director, Department of Medical Oncology, Rajiv Gandhi Cancer and Research Center, Delhi. And the panel discussion will be moderated by Dr. Ulas Batra. He is Co-Director and Chief, Department of Thoracic Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, Delhi. So over to you, Sumant, for the first presentation, that is Tisle in lung cancer.
Thank you, sir. Thank you for having me here. I'm really sorry my laptop conked off, so I'll be joining from phone. So I'll request the MICE team to please help me with the slides. So good evening, everyone. Good evening, Vatsa, for giving me an opportunity to speak on this. I think last 1.5, 2 months have been very interesting in the field of immuno-oncology with many new drugs coming in the IO segment. So today we'll be talking about the new IO in lung cancer, the current evidence and the future directions. Can I have the next slide, please? So coming to the background, if we talk about lung cancer, we know how common this is. It comes in the five most common cancers, and lung being the second most common cancer in the males. Next one. So incident and mortality are 2x higher in men than in women. Lung cancer mainly occurs in people of 65 years of age and older, although we see it in varied ages. And tobacco epidemic is one of the most common causes of lung cancer. Next, please. All of us know about the histological classification, non-small cell being around 85%, out of which adenocarcinoma is the most common variant. And this is the variant in which we find the maximum number of mutations, both in adeno and squamous. Next one, please. So coming to NSCLC, again, you have two patterns of treatment now. One is the driver mutations where you find out the common EGFR L cross mutations, and other is the driver negative mutation where the immune checkpoint inhibitors play a major role. Next one, please. So the current standard of care. So we all know how we are treating stage 1, 2, 3 being divided into resectable and unresectable, where surgery followed by adjuvant therapy or chemoradiation followed by immunotherapy consolidation is the treatment of choice. Next one, please. So consideration for systemic therapy again depends on the performance status, the histology, the molecular targets, and the whether the patient is a immunotherapy candidate or not. So I think lung cancer has become more and more advanced in the treatment scenarios and more complicated as time goes on. Next one. So again, stage 4 NSCLC negative for any actionable molecular markers in both PD-1 inhibitors, monotherapy versus PD-1 inhibitors in combination to chemotherapy are being used. And we'll go into detail and delve into this. Next one, please. So newer PD-1, PD-L1 inhibitors on the horizon. Next. So these are the 3, 4 drugs which have come up. First is the Tisli, which I've been speaking on. It has a lot of EMA approvals. It is approved in first line non-squamous NSCLC with PD-L1 more than 50%. First line squamous NSCLC with chemo. Second line NSCLC monotherapy. First line gastric cancers, first line ESCCs with chemo PD-L1 tap of more than 5%, and second line extended stage small cell cancers as a monotherapy. US FDA has also approved it in multiple indications. Next is the toripalimab, which we have again been exposed to. It has nasopharyngeal approval, which is right now approved in India. Then we have the serplulimab, which is approved in small cell lung cancer, and the next, which is not yet available in our country, but again a newer immunotherapy, which is semiplimab, which is approved in non-small cell lung cancers and few other cancers like cervical and basal cell. Next one. So this is the rationale 307, which is for Tesli in first line squamous cell NSCLC. It is an open label randomized multicentric phase 3 trial comparing the efficacy of Tesli with chemotherapy versus chemotherapy alone. The eligibility criteria was as per the global guidelines of immunotherapy, stage 3B or metastatic stage 4 squamous NSCLC, no sensitizing mutation, and resist measurable disease. But there were three arms initially. So one arm was Tesli plus Paclicarbo, the other was Tesli plus nab-paclicarbo, and the third arm was chemotherapy alone, which was the standard Paclicarbo arm. And it was a very well-matched study with around 120 patients in each of the group. The maintenance arm was tislelizumab 200 mg alone, single drug, after 4 to 6 cycles, and crossover was allowed upon disease progression in the chemotherapy arm. The primary endpoints were progression-free survival, independent review committee. Secondary endpoints were ORR, DOR, OS, and safety profiles. Next one. So if we see the efficacy, addition of tislelizumab to the platinum-based chemotherapy doublet as first-line treatment for locally advanced or metastatic squamous NSCLC showed a meaningful benefit in the PFS and a higher ORR and longer DOR. So in both the subgroups, that is comparison between ANC and BNC, that is Paclicarbo versus plus immunotherapy versus Paclicarbo, or nab-paclicarbo versus the chemotherapy plus immunotherapy versus the Paclicarbo arm. So in all of both these, the stratified HR with a 95% confidence interval was 0.45 and 0.43, which was quite similar. Next. So this is the PC versus arm A, arm C, and arm B, arm C. If we see the PSF subgroup analysis wise, I think both the sides, it is showing a benefit in most of the thing. The only interesting thing is that there is a little bit more advantage in 3B than 4. Again, that is something which we have to discuss. The PDL expression was again seen in all the subgroups, and the advantage was in all PDL positive patients. Next one. So coming to the safety in arm patients with major TARs. So as we have seen in all immunotherapy drugs, and now as we have grown up with these immunotherapy drugs, now there was no new safety signals which was identified as with tislelizumab to monotherapy alone. Next one, please. So this is another rationale 304, which was Tisli in first line non-squamous NSCLC. So again, in this arm, the if we see it was a similar eligibility criteria, and the patients were divided into randomized 2:1 into tislelizumab plus cisplatin or carboplatin with pemetrexed or the chemo doublet alone. And the maintenance was between the immunotherapy plus PEM maintenance versus PEM maintenance alone, and this was continued upon till upon progression of disease, loss of clinical benefit, toxicity, or withdrawal of consent. And in the pemetrexed or the chemotherapy arm, there was a optional crossover to the immunotherapy arm. The primary endpoints were again PFS, which was a review committee, independent review committee reviewed, and secondary endpoints were ORI, DOR, OS, and safety signals. Next one. So in this subgroup also, the addition of tislelizumab to chemotherapy resulted in a significant prolonged PFS, higher response rate, and longer responses compared to the chemotherapy. The hazard ratio was 0.63. And we can clearly see the graphs on the right side with the divergence on the red line, which is the arm A. Next one. Side effects. The incidence of adverse events reported with chemo plus IO was consistent with the known tolerability profile of PD-1 inhibitors in combination with chemotherapy. The most immune-mediated AEs were grade 1 and 2, and most of them did not lead to any treatment discontinuation. So again, this drug, when we use, most of the side effects are as what we have seen in other PD-1 inhibitors. Next one. So immune-mediated adverse effects, pneumonitis, hypothyroid rash. So most of them were grade 1, 2, and there were grade 3, grade 4 pneumonitis, which was reported in these. But again, this was quite consistent to the global data of immunotherapy, which we have. Next one. This is 303, which was second line NSCLC as a monotherapy. Tislelizumab monotherapy was again 200 mg every 3 weeks was compared to docetaxel, a 2:1 randomization, and the treatment was continued until unacceptable toxicity or progression of disease. So if we see this, again, the overall survival is the primary endpoint in ITT and PDL1 of more than 25% population. Next one. So treatment with tislelizumab demonstrated a significant prolonged OS, PFS, DOR, improved ORR in the intention to treat population, as well as PDL1 more than 25% population versus the docetaxel. The OS in the PDL1 arm was 0.53 hazard ratio. Next one. Efficacy, if we see subgroup wise, it again showed that the patients with a higher PDL1 had done a little better than those with a lower PDL1. Next one. So efficacy of biomarker analysis, it is post hoc biomarker analysis in the biomarker evaluable population. The Notch 1 to 4 mutation showed a potential association with better TC efficacy, which was correlated with OS and PFS benefits. So this is again an interesting subgroup analysis. And if we see, we have seen that the patients with mutation negative wild type cancers have done the best with the immunotherapy, which is again reported with the global data. Next one. This is the PFS. Coming to the rationale or the safety of the rationale 303, it was well tolerable, manageable safety profiles as consistent with other PD-1, PDL1 inhibitors, and the grade 2 incidence was quite similar as the data reported earlier. Next one. So this is a network meta-analysis NMA where tislelizumab versus other PDL1 agents in the first and subsequent lines in metastatic disease have been compared. Again, cross trials are difficult, but this meta-analysis has tried to give us some answers. Next slide, please. So for PFS, Tisli plus chemo was statistically significant or more favorable than nivolumab monotherapy, atezolizumab plus chemo, nivo plus IPLI combination therapy. So now again, this is a very difficult thing to interpret, but the basic take home we can take is that this drug is definitely active and it has shown good results in first line non-small cell lung cancer. Although I personally never like to compare, will never like to compare a cross trial data, but again, it can tell us that this drug is quite efficacious, if not superior, inferior to any other drug. Next one, please. So this is again first line NSCLC with PDL1 of more than 50%. Regarding the PFS, Tesli plus chemo was ranked the most efficacious. So next one. This is in the second line NSCLC of any histology. Again, tislelizumab has shown to be an efficacious option. Next, please. So, coming to conclusions, if we try to derive some conclusions from this meta-analysis, they have said that tislelizumab is highly active and efficacious PD-1 inhibitor, and these findings provide clinical evidence for the benefit of representing an additional immunotherapeutic option for patients with advanced or metastatic first line or second line NSCLC. So, we should forget whether it was better, which the meta-analysis has shown, but clearly from these meta-analysis we can conclude that this drug is also an effective option of immunotherapy in NSCLC. Next one. So coming to the clinical trial setting, other lung cancer settings, it has been used in neoadjuvant and adjuvant settings in small cell. Again, the results are quite promising, although the approvals are awaited. Next one. So pivotal clinical trial summary to this. First line squamous NSCLC, Tisli plus paclicarbo or nab-paclicarbo shows a statistically significant improvement in the tumor progression and response as compared to paclicarbo alone. First line non-squamous NSCLC, again, it has shown a clinical longer survival benefit and tumor response in patients with more than one PDL1 score. And second line NSCLC, Tisli monotherapy has also shown to be quite efficacious in both OS and disease progression as compared to chemotherapy. Next one. Thank you for your patient listening. I think these newer drugs will give us a lot more options clinically, both in the clinical settings and as well as in the financial settings. Thank you, sir, for the opportunity.
Thank you, Sumant, for bringing out the key points about this immunotherapy drug, and of course, drawing some comparisons. And as very rightly pointed out, cross-trial comparisons are not a very fair way of going about. But the drug itself has a very robust activity, and both in the second line and the front line settings, and it brings us another option in the first line treatment of these patients. So stay on for the panel discussion, and I take this opportunity to invite Vineet now. Vineet, over to you. Eagerly awaiting your talk on impact in esophageal cancer.
Thank you, sir. So, after the talk on lung cancer, we switch gears. We come to the esophageal cancer, especially the squamous cell carcinoma of the esophagus, and how the next generation immunotherapy has impacted in its treatment across the paradigms. So, next slide, please. Coming to the disease background, we see that this is a disease which is common for the males as compared to females. And amongst the males, it ranks on the third. And if we combine both the males and females, in both sexes, it ranks amongst about the fifth. So this is the Globocan data of 2022. Next slide, please. So, as I had already said, that the squamous cell cancers are higher in men as compared to women, that is 2.5 times higher. And 85% of all esophageal cancer cases are squamous histology. Having said that, they are the commonest in the esophagus. The stage at presentation is about 40% metastatic in these cancers, And since about 40% are metastatic at presentation, that translates into a dismal survival of about 20%, and which falls further about 6% for patients in advanced stage disease. So most of these patients are squamous cell, and most of these, about 40%, come at an advanced stage, and those which come in the advanced stage have a dismal single digit survival that is about 5 to 6%. Next slide, please. Coming to the pathophysiology, squamous cells are mostly located in the upper third and the middle third of the esophagus. You might have some in the lower third and the G junction, but that is the area which is privy to adenocarcinomas, which accounts for about 14%, and rest are all squamous cell. And both of them have a poor prognosis, but if you compare adeno versus squamous, squamous takes the edge and has a very poor prognosis. Next slide, please. So how does the cancer form? All of us know that you have the chronic inflammatory cells, and then you have the DNA damages, or you have the genomic instabilities. You can have molecular events which lead to an adaptive response and change it from hyperplasia to intraepithelial neoplasia. And after that, you might have loss of certain uh, genes, like you have loss of TP53 or CDKN2A, or gain of CCND1 or SOX2 or NFE2L2. So when that happens, you have frank infiltrating carcinoma, which arose basically from the hyperplasia per se. Next slide, please. But this takes generally about 80 to 90 months. Now, when we go into the conventional NCCN guidelines, we find that if you have the first line therapy, oxaliplatin is preferred over cisplatin, and that can be combined with 5-fluorouracil or capecitabine as a standard. Along with that, if the CPS score is done and CPS score is more than 1, then we are spoilt for choices. We find that we can have nivolumab, pembrolizumab, and tislelizumab for these kind of cancers. But if you have MSI high, or there is deficiency of the MMR, you find that independent of the PDL status or the CPS scoring, these patients can be given pembrolizumab, dostarlimab, or ipilimumab, nivolumab as agnostic indications for esophagus or esophagogastric junctions. Other recommendations apart from 5-FU and capecitabine or oxaliplatin can be paclitaxel with or without carboplatin and cisplatin. So this was the first line. Next slide, please. You come to the second line, then we see that we can have nivolumab, pembrolizumab, and then we have data for second line tislelizumab, which I would be alluding to you later. Again, you have agnostic markers for NTRK, MSI, and TMB. If you have them, then of course you can use a host of immuno-oncology drugs like entrectinib, pembrolizumab, nivolumab, and dostarlimab. If you have the BRAF V600 E-mutated tumors, then definitely you can use dabrafenib and trametinib as a combination. RET is quite rare, it's about 1%. If you have that, then definitely in second line you can use selpercatinib for that. Next line, please. So ESMO guidelines for advanced ESCC show that if you have the PDL1 CPS more than 10, then you can use pembrolizumab. Earlier it was CPS more than 1 for pembrolizumab, but later on as studies matured, they found that the actual benefit was when the CPS was more than 10. Then only pembrolizumab could be used in isolation. But otherwise, if you have TPS of more than 1, then you can use nivolumab, chemo, nivo-epo EP, or if both are negative, then you can have platinum fluoropyrimidine. And as far as the attraction study, you can have nivolumab. Next slide, please. So what are the newer combinations? Newer combinations, as Dr. Sumant had already alluded to you, if you see in the esophageal squamous cell cancer in first line, you can give it as tislelizumab in combination with chemotherapy. But in second line, if you have options, then tisle can be given as a monotherapy in these patients. This is according to the EMA guidelines. If you go to the FDA guidelines, they are almost similar. First line in combination with chemo and second line in monotherapy. This has been recently approved by the DCGI of India. And here again, in second line esophageal squamous cell cancer, you can use as monotherapy. But for the first line, I think the approval is pending. There are other drugs like toripalimab. Again, they can be used in esophageal squamous cell cancers in first line with chemotherapy, and so is seripalimab, which also can be used as first line as alone. There are other molecules like sintilimab and camlizumab. They are at present approved only in China, but I think it's a matter of time that they will come into the guidelines subsequently. So broadly speaking, tislelizumab can be given as first line in addition to chemotherapy. And if it is second line, then of course it can be given as monotherapy. And here you use the PDL1 TAP scoring instead of the PDL1 CPS scoring. Next slide, please. So everything has to be backed by data. So when you talk of tislelizumab, I would be discussing two trials. One, which is the Rationale 306. Now this is in
Vineet, are you there? Can't hear you.
I think there is a network issue.
Yeah,
He
yeah.
should be joining back.
So I think by the time he joins back, so what Vineet had presented in the previous slide was the fact that the esophageal squamous cell carcinoma has a couple of options today. And we know from the keynote 590 that there was the hazard ratio was good as far as all comers were concerned. But there was actually no benefit for PDL1 less than 1 and even less than 5. And in fact, only more than 10, there was a benefit. So between 1 and 10 for Pembro, there is no benefit. So that's something very interesting about the drug. And if you talk of the Nivo trial, again, Nivo did not show benefit up to 5%.
Sorry, sir,
Yeah.
but actually my
Please go ahead. Go ahead.
desktop turned off.
I
I
was
don't know
just,
why
just
there is some update going on.
I was
So
just filling up in between. Okay, let's
I'm extremely sorry for that, sir.
not at all.
I'll continue on from my mobile. I'll keep the video switched off. So Rationale is the trial in which tislelizumab plus chemotherapy versus placebo for the advanced or metastatic first line uh, combination has been used. Next slide, please. So this, as you can see, has been a global trial, although it was a retrospective trial. And here you find that about 75% of patients were from Asia. Unfortunately, not from India, but then, of course, Korea was there, Japan was there, and China, mainland China, and Taiwan. They were there. There were 49 sites, and there were 370 patients in all from them. And rest of the world was about 25%. So a good distribution. And in a way, it helps us because there is definitely a difference between the Caucasian and the Asian data. So this drug gives us an opportunity to see whether it works in the Caucasian data only, or it works in the Asian data, or both. Next slide, please. So the key eligibility criteria for these patients were unresectable, locally advanced or metastatic esophageal squamous cell carcinoma with no prior systemic treatment for advanced disease. The ECOG PS was 0 to 1, and it should have a measurable disease as per the RECIST criteria. And there was a 1:1 randomization in which tislelizumab 200 milligram IV every 3 weekly was added to the chosen chemotherapy, which could be a platinum and a fluoropyrimidine, or could be platinum and paclitaxel. Now, this was a good point about this study because they gave the physician discretion to choose between option A and option B as far as the chemotherapy protocols were concerned. Because it has been seen that in squamous cell carcinoma, some physicians, they prefer platinum and paclitaxel combination, whereas others prefer the platinum and fluoropyrimidine combination. And this was compared against the current standard, that was the investigator chosen physiotherapy, chemotherapy with the matching placebo. And the primary endpoints in this was overall survival in all randomized patients. And the secondary endpoints were the progression-free survival, the duration of response, and also the quality of life indices. Next slide, please. So this you can see as far as the overall survival is concerned, it had a robust hazards ratio, which led to a reduction in the risk of death in about 34% patients. And that again translated into a 6.6 months additional overall survival in these patients. So you have a median overall survival of about 17.2 months against 10.6 months, which was seen in the conventional chemotherapy with a HR of 0.66, which was statistically significant. Next slide, please. So the next question was, like in other studies, was there any benefit if the PD-L1 score was more or was it low, as it was seen in the squamous cell carcinomas? Here you can see whether the PD-L1 score is greater than 10 or the PD-L1 score is less than 10. The median overall survival is about 16.6 to 16.7 months against the control arm, which is about 10 months. And both are statistically significant. So the OS benefit with Tisle plus chemotherapy was observed regardless of the baseline PD-L1 expression. Next slide, please. So from the overall survival, we come to the progression-free survival, and you find that the median PFS is about 7.3 months against 5.6, which was in the placebo plus chemotherapy arm. And PFS was significantly improved with tumor response greater and more durable with Tisle plus chemotherapy. And so was the duration of response. You see that it was about 7.1 months against 5.5 months. Next slide, please. Now, this is very important in any trial. When you see the safety and tolerability, you see that the predominant adverse events were myelosuppression in form of anemia, decreased neutrophil count, and decreased white blood cell count. Along with that, of course, was fatigue and GI symptoms, and in a small proportion of patients, there were having peripheral neuropathy. But this, as you can see in the graph, they were seen in both the patients which were in the control arm and as along also in the test arm. More than even equal to grade 3 events was seen in about 66.7% patients as compared to the one which was in 64.5 patients. And the discontinuation was seen in about 31.8% patients as against 22.4% patients in these patients. And thus, we can say that the grade 3 or more than grade 3 events were about 8.6% patients versus 1.6% patients in patients who were treated with this drug. Next slide, please. So switching gears now from the first line to the second line trial was known as the Rationale 30 trial, in which it was a single agent tislelizumab versus the chemotherapy for advanced metastatic esophageal squamous cell cancers. Next slide, please. So this was the study design or the study schema. The key eligibility criteria were the advanced metastatic squamous cell cancers, progression during or after the first-line systemic treatment, with a good ECOG PS of 0 or 1. They were randomized in a 1:1 fashion for tislelizumab 200 milligram IV 3 weekly versus investigator-chosen chemotherapy, which could be paclitaxel or docetaxel or irinotecan, whichever the physician's discretion was there. Treatment was continued till disease prolongation or intolerance or toxicity or treatment withdrawal. And the primary endpoint, like the previous study, was overall survival in all randomized patients. The key second point was the overall survival in patients with the TAP score of greater than or equal to 10%. And the other secondary endpoints were the progression-free survival, the quality of life indices, the overall response rates, duration of response, and safety. Next slide, please. So we find that there was an overall survival of about 2.3 months in addition to chemotherapy. And again, this was there in patients who had a TAP score of more than 10% subgroup. And this was slightly more in these patients, about 1 to 1.2 months more as compared to the overall patients. Next slide, please. And so was the PFS, which we see in these patients. The PFS was also increased in these patients, and Tisle was associated with a greater overall response and more durable tumor response than chemotherapy. This was about a couple of months more as compared to the chemotherapy drugs. Next slide, please. Coming to the safety and tolerability, Tisle demonstrated a generally tolerable safety profile compared with chemotherapy in overall population, and it had lower rates of grade more than equal to 3 adverse events and lower rates of treatment discontinuation. So if you see, there are about 5 patients in the Tisle arm which had mortality versus 7 in the chemotherapy arm, and about 17 patients discontinued treatment in the Tisle arm versus 33 patients in the chemotherapy arm. So that speaks about the safety of the drug as compared to the current chemotherapy standards. Next slide, please. So a word about the TAP and the CPS scoring. Next slide, please. Here we are, can I have the next slide, please? Here we are talking about the TAP scoring. Now, when you say TAP scoring, TAP is basically the total percentage of the tumor area covered by the tumor cells with any membrane staining above the background, and this is in a ratio to the tumor-associated immune cells with any staining above. So you have the tumor area which is covered by the tumor cells with any membrane staining, in the background versus the tumor-associated immune cells with any staining above the background. So this is slightly different from the CPS scoring, in which you have the PDL1 positivity in the tumor cells versus the tumor cells which are there in the background. But then there was a concordance which was seen in the TAP and the CPS, which you can see by the PPA, that is the positive percentage agreement between the TAP score and the CPS score, and whether it is 1% or 5% or 10%, which you can see in the rational trial, that was the first line treatment, you find that there is a great concordance between the TAP and the CPS scoring. Next slide, please. Again, in the second line, when you used rational 302, you find that there is a concordance, or the PPA, which is the positive percentage agreement between the tumor area positivity and the combined score, which is their combined positive score, whether it is again 1% or 5% or 10%. So whether you use the TAP score or CPS score, it is almost concordant as far as the grading of this scoring is concerned. Next slide, please. So now we can have some indirect comparative data. When you see the trials which have been pitted against each other, if you just glance at the median overall survival, you find that with the rational 306, that is first line, where Tisley was combined with chemotherapy versus chemo alone, you find that the median overall survival is 17.6 months versus 10.6 months. And if you just glide along this only, you find that this is the highest along the whole of the trials which have been pitted against one another. And same goes for the median progression-free survival, which is the highest with Tisley. And you see that the hazard ratio is 0.62, which is very, very robust. Again, when you talk of the duration of response or the overall response rates, they are again, matching or higher than most of the trials. So when you talk of the EU guidelines, or you talk of the FDA guidelines, or you talk of the DGCI guidelines, that is the reason probably why it has been taken into the treatment protocols, and it has been ratified simply because of the higher survival rate and higher response rates, and also the duration of response in these patients. Next slide, please. If you do again an indirect comparison on the second line, that was the rational 302, you find that the overall response and the progression-free response again is matching in terms, whether you see it against Keynote and attraction studies, that is the pembrolizumab and the nivolumab studies. Next slide, please. So the key messages are that immunotherapy molecules offer a more targeted approach as compared to the chemotherapy, enhancing the potential of the body's immune system to act against the tumor cells. And immunotherapy for the esophageal cancer, whether it is alone, which we have seen in the second line, or in combination, which we have seen the first line esophageal squamous cell cancers, it has shown to significantly improve the outcomes for patients with tolerable safety profile. So if you talk of first line, Tisley plus chemo, you have a median overall survival of benefit of about 7 months, which is humongous. If we talk of second line, where Tisley was used alone, there again, there is a definite overall survival benefit of about 2.5 to 3 months. And that translates into a good duration of response, which is also very important in these patients who have advanced metastatic disease. The clinical evidence from newer PD-1, PD-L1 inhibitors showcase their potential as additional immunotherapeutic options for patients with advanced or metastatic esophageal carcinoma. So I think that was my last slide. I thank you for your patient hearing.
Thank
Over
you.
to you, sir.
Thank you, Vineet. That was a very lucid, very patient discourse, I must say, and bringing the various points about the drug to the fore, and especially the TAP score, CPS, dwelling on the first line, second line data, and showing us the meta-analysis. And indeed, this is another option for us in this difficult to treat disease. And with that, we move on, and I can see Ulas there. Ulas, welcome.
Thank you, sir. Thank you for
And
the
let's
invite.
get going. Let's get going. I've already introduced you in absentia. I do that again. You are the co-director and chief, Department of Thoracic Medical Oncology at the Rajiv Gandhi Cancer Institute and Research Center, Delhi. Thank you so much. And let's go on. Over to you for the panel discussion. Please invite your panelists, and also Sumant and Vineet also to the panel discussion. Thank you.
Fantastic, sir. So I think thank you for the invite, and thank you. I think Dr. Sumant and Dr. Vineet are already here. You have already invited them, and as per the list that I have received from the event manager, you are one of the star panelists, sir. So I'm requesting you also to, unmute yourself and de-video yourself.
I
And
thought I can only ask questions.
no,
How
no,
am
no,
I
no, sir.
supposed to answer
This is
questions?
the new normal, sir. Things have changed.
Thank you.
So requesting Dr. Talwar and Dr. Sumant also, and Dr. Abhinav is there from Dwarka, to please unvideo them and unmute them. And we will make it quick because after Dr. Talwar's discussion, I think nothing really remains to be said. I think he has said the thing stage very clear that ultimately it is going to be immunotherapy in this. Let me start with a real-time case and my disclosure and confidence and conflict of interest for today. And this is not a video which is going wrong. It's actually different. It's nice. It's otherwise it's nice to talk about esophagus for a change. You know, it has already been breast cancer, lung cancer, colon cancer. We have been talking left, right, and center. So I think it's good to be talking about esophagus. It's going to be different and it's definitely going to be fun. So let us start from here. We have a 45-year-old female who is a non-smoker. She came to us with a history of dysphagia. Endoscopic biopsy was done, which said an esophageal growth. Biopsy was suggestive of a squamous cell carcinoma. And PET scan, Abhishek, I think I have kept it for everybody's thing. This is just a screenshot that I have taken from the PET scan. Eccentric wall thickening in the mid and lower thoracic esophagus. 10 centimeter long segment at D6 to D10 level. Evidence of intraluminal extension. No significant luminal narrowing is noted. There are some paraesophageal lymph nodes and gastrohepatic lymph node also has been there. So how will you, what is the next investigation? How would you proceed with this case? You directly then to send them surgeons, do a EOS, do something else, biomarkers. How can we not talk about biomarkers when I am there? What do you do?
Yeah. So this seems like a localized, locoregional esophageal cancer, sir. There is no evidence of intraluminal extension. So yeah, generally we discussed this case in a tumor board meeting because I think it's a squamous cell carcinoma, 10 centimeter D6 to D10. So generally for squamous cell carcinoma mid-thoracic esophagus phase, we are treating with cross protocol. So upfront, we are not doing any biomarkers, sir. Generally, we start with radiation and chemotherapy. At our center, we are using weekly paclitaxel carboplatin, 50 mg per meter square AUC2. Generally, we have to discuss this in a tumor board meeting because esophageal cancer patients, a lot of these patients may have issues with dysphagia, nutritional issues. So we have to make them come in contact with dietitians as the treatment goes on. And then after a while, we generally repeat a scan to see the response and followed by surgery. She's a young female.
Absolutely. And one thing which I like the most about this was you're calling a 45-year-old female a very young female. As my age is growing up, 45, 47 being called young is fantastic. Dr. Vaid, 45 is adolescent nowadays, sir?
So it all depends on the age of the physician.
That is why, sir.
Yeah.
So I like to call them young. Okay. So Abhinav, I'll come to you and I'll come to Dr. Vaid later. Abhinav, are you here? Dr. Abhinav Narwaria?
Sir, I am here, but I couldn't listen to it because I was on a call. Please, sir, I'm sorry
No
for
worries,
that.
no worries, no worries. We were just saying that a 45-year-old female is a very young female as far as the treating physician is concerned.
Yes, sir, I
So,
also consider 45 as young.
correct, fantastic. So Abhishek, Abhinav, sorry. Abhinav, we have presented this case. A young female has come with a localized esophagus. Now, my specific question to you is, if this was lung, we would have done an EBUS and found out about the mediastinal lymph nodes, because we always say there's a 30% chance of this being, false positive.
Yes, sir.
Doesn't happen at our center. They don't do an EUS and do an FNAC biopsy. What happens at your
Yes.
center? And do you always stage your lymph nodes also, or do you presume it is positive?
Sir, actually follow that, that Devita's, that 4 pictures, if it is a N2, so every time I'm not going to do a EBUS, and sometimes I presume it to be positive only.
Okay, I think most of us were presumed to be positive. I asked my radiation oncologist this, and he said there's a difference between this and lung. Anyway, in the esophagus, they're going to include this into the radiation portal. And anyway, surgery will be done, and the treatment will not really change more than T1. So they presume it to be positive, which is absolutely all right. So I think Dr. Abhishek has already given his chance that they follow a NACTRT followed by surgery protocol. Any role with the great data that Dr. Talwar has shown? Do you think neoadjuvant only chemotherapy or neoadjuvant chemo immunotherapy is a option, or you're sticking on to NACTRT followed by this? And why not a definitive CTRT? Abhinav, and then Dr. Vaid. Okay, seem to have missed Dr. Abhinav. Dr. Vaid, sir, what happens at Medanta?
This is this is an area where immunotherapy. Look at the trials. Everything would come from the trials, and how many patients fitting into this description were part of the whether that is the Jupiter or whether that is the Tisley trial or any of the trials with Pembro-Nivo. Now, most of us would send these patients for a definitive chemoradiation and then to the surgeon for some sort of a surgery, a definitive surgery, to put it that way.
Correct.
But if there are signs of inoperability, right? Because all that you have to define is this potentially operable or not?
Absolutely right, sir.
That's the dividing line, I think.
Correct. So absolutely agree with Dr. Vaid, and that is where the wisdom comes from. The first question that I also tell the patient is it operable or inoperable? If it's operable, then we are going to go ahead, as Abhishek rightly said, with the neoadjuvant chemo rads, because there has been a good amount of PCRs that we have seen with this. But the PCR is to the tune of 45%. Can we increase the PCR? Now, there is a new trial which was presented in ASCO 2025 this year with Tesley plus chemo. It phase 2 trial which has shown a good PCR rate, but it has not yet been compared with a cross protocol. So for all of us, cross protocol remains the standard, which is absolutely all right. And this is what we all do. So this patient was tried on pre-op RTCT. Abhishek has very rightly said that the choice of chemotherapy is going to be weekly Paclitaxel carbo. Nobody really gives 5-FU cisplatin nowadays. Capecitabine is also not really considered is proper, because most of the time patients will have dysphagia, and it's difficult if they have a Riles tube or something to take care of that. So that is where. So this lady basically received 23 fractions radiotherapy and 5 fractions of weekly Paclitaxel carboplatin chemo. She tolerated very, very well. The reassessment after this was done here, where they said there is a good partial response to treatment with metabolic active residual thoracic esophageal wall thickening, which shows interval changes. So absolutely very classical way. Dr. Talwar, are you here? Vineet? Okay,
Yeah. Plus, I'm very well here. When you are there, I'm here.
fantastic.
Yeah,
Let's
tell me.
go. Let's go together to a new institute. That will be fun.
Yeah. New institute or new patient?
It's
New institute. There are a lot of Dr. Vaid is now suddenly interested. Yes,
Dr.
Dr.
Vaid
Vaid.
is
it
smiling.
takes two to tango.
Okay, Dr. Vaid was just about to give us an offer.
No, which two we have not told you.
No, you and me going. I'm telling you this. Okay, fine. So this patient, okay, we need a lot of time. These patients will come and they don't want surgery. So, and let's say this patient had a good partial response to therapy, and let's say there was a significant response to treatment, and you an endoscopy, and there is no residual disease which is identified. What do you tell them at that time? Is surgery mandatory, or they can get off with CTRT itself?
Now, this patient had a good partial
This patient,
response.
yes,
He
but let's
didn't
say
have
somebody,
a.
I'm asking you a different patient who has a significant response to treatment with a 43 gray 5 fraction Bakley carbo, significant response to treatment, you did an endoscopy, nothing is there at 6 weeks. Will you?
And the patient has no complaints or anything.
Patient doesn't want surgery. She says, if you can get it avoided, I'll be happy. But if you say, I'll go ahead with that.
So, if the patient has had a clinical and a radiological CR and is not keen for going for surgery, then a small percentage of patients can be put in the wait and watch category and very closely watched after doing serial biopsy at inception and then following radiologically over a period of time.
Okay, fantastic. So watchful waiting is an option. Abhishek, what would you say?
I think if we are using a definitive treatment, so this discussion should happen prior to initiation of pre-op CTRT.
Correct.
But if we are using a definitive treatment, the dose of radiation is going to be higher there.
50.
And as Dr. Talwar sir rightly said, that if we are putting the patient on observation, we have not only we need to do a radiological observation, it is also an endoscopic observation that is needed. So surveillance will require a careful discussion with the family that you are required to go regular endoscopies as well as CT scans before putting you on surveillance.
Okay. I am not going to ask this question to Abhinav because Abhinav is driving and I don't want to distract him with a question like this. I'll go to Dr. Vaid. I'll ask you a simple one, Abhinav. Abhi, you concentrate on driving. Dr. Vaid sir, surgery is a must. So this patient has got a 43 gray. As Abhishek rightly said, if somebody would have taken 50 gray, we would have still been okay. But this patient has not had a proper definitive CTRT dose, really. Intent should have been decided before, but patients don't listen to us. What to do, sir?
No, but then there will be a subset of patients where we know that we are never going to operate on them.
No, this patient was considered for a neoadjuvant approach only, sir.
This patient would benefit with surgery following these doses of radiation and chemotherapy. I think it's the skill and the convincing power of the treating physician.
Fantastic.
Which prevail upon the patient.
Pearls of wisdom once again. And I would actually agree with Dr. Vaid and said, and Abhishek also, and even with Vineet. But all efforts should be made to tell the patient upfront. Actually, I always say Sam, Dam, Dand, Ved, and I actually feign anger and said, Naini, you should have done this before. You have to go and talk to them over there. And we should counsel this patient for surgery. However, if the patient does not agree for surgery, absolutely right that she has to be under radiological and endoscopic monitoring. Trials are underway which will tell whether we can avoid surgery, but at present surgery should really be offered to them.
Last, the
Yes,
point under discussion would be that esophageal cancer is a very unforgiving disease.
Correct.
It's an aggressive disease.
Correct.
Once a recurrence, then you have missed the bus forever.
Correct.
And then whatever happens upfront, I think that's a story for all solid tumors.
Correct. Absolutely. Your first bet is the first batsman has to be the best batsman. That's absolutely all right. As in this case, the patient had a good partial response, but when she underwent surgery, the histopath was YPT3N2M0, which basically said that, a PET scan is not really a very good modality to really find out things like that. So now, Abhinav, I hope you are now. So this patient, pre-op RTCT, surgery, now has a YPT3N2M0. How would you do? Will you do any biomarkers? Will you do a PDL1 testing? Vineet spoke about TAP testing, CPS testing. Will you do anything of this sort? Dr. Abhinav.
Sir, I would like to do a PDL1 CPS testing, but regardless of that, I will offer the patient benefit of adjuvant nivolumab, which is now a standard of care. But definitely, PDL1 CPS testing is going to tell me how much that patient is going to benefit with adjuvant nivolumab, because at that time patient has already underwent two treatment modalities, and I need to disclose that this is not a good disease. It is going to recur.
Absolutely right. Abhishek, any differences in opinion? Abhishek, you are muted.
So generally at this point, I don't do PDL1, sir, because in the trial Checkmate 577, I think the benefit was seen in both squamous as well as adenostomology, and the benefit was seen across the subgroup. Moreover, the trial was designed keeping in mind the all-comer patients, not PDL1 specific. So I would offer and not test it.
Okay, so
plus it's a bad disease, as Dr. Abhinav said, that huge
Absolutely right.
burden despite giving CTRT. So this patient is
Absolutely right. So, I think nobody really will give more chemotherapy. There were times that people were used to give DCF after this. I think we have passed that time now. No more DCFs, no more Paclitaxel carbos and all. And, do you really have to? I will not ask this question to Dr. Ved. I'll ask this question because whatever Dr. Ved says is convinced. Whatever we said, we are persuading the patient. So we are not saying this. Vineet, do you really have to convince your patient for adjuvant immunotherapy now, or they are like, okay, reasonably okay? So in our setup, how many of your patients would take adjuvant immunotherapy?
I guess about 20 to 25%, because finances, as you also know, has a very big role whenever you talk of immunotherapy drugs, as 80% of them are out of pocket.
Correct. Absolutely right. So, Dr. Ved, convinced? You are
Majority would
convinced
come
how
and
good the patients are?
majority would come and ask you,
Correct.
and even for non-indicated conditions.
Correct. But for
situations.
indicated patients, they will not take.
Vedanta, they will ask definitely.
So everybody asks for everything,
Yes.
And when it comes to the brass tacks, you sit down and talk about the costing and all that. Thankfully, now with the PAP programs, we are able to access many more treatment cycles. But it's a uphill task.
It's an ask. It's an ask. I
The
think I
finances
would.
are not that very many.
Correct. It is, even and especially, after radiotherapy, chemotherapy, and surgery, when the patient comes over there, they just want to go home. Ki, Doctor Sahab, bahut ho gaya. We'll come back in 3 months' time and then we will see.
They're physically, mentally, financially tired,
Tired. I mean, correct. They would have spent approximately around 8 to 10 lakh rupees on that. And then you tell them 10 more lakh rupees, and then it really becomes an issue. But so this patient was tried on immunotherapy. Something which I just saw last month, Abhishek. This was the update of Checkmate 577, which was presented at ASCO. As you rightly said, 240 mg and placebo patients were giving. But if you look over here, the median OS was fantastic, 16 months advantage in the median OS, but the HR was 0.85 and the p-value actually was not significant. Statistically not significant because a lot of people got immunotherapy later down line also, although there was 16-month advantage. What is very, very concerning for me is this. Look at this, PDL1 CPS less than 1, it is 39 versus 52.8. To me, I was absolutely what you were saying. I was a believer of that. We didn't ever do PDL1 testing with this. But after this data, if I really have to persuade someone, I will be persuading that patients with PDL1 more than one actually. And I will not really, I will just, for the sake of writing, by and large, write over there, discuss regarding immunotherapy. But I think this data is too strong. Again, subset analysis. We can torture the data wherever we want, but this 39 versus 52.8 is absolutely very, very concerning. And I think although PDL1 is an imperfect biomarker, but that's the best one do we have. And following this ASCO, I am going to use this data. If somebody doesn't really have money with a PDL1 negative, I'm not really going to force them into it. Dr. Ved, sir, your thoughts on this?
Exactly. This mirrors the data from the advanced setting as well.
Yes.
in the subset of patients which were less than 1, PDL1 less than 1, it was actually detrimental.
Yes.
So less than 1, please do not force your patients, in any setting, actually.
Correct.
With me. Yeah.
So I totally believe, sir, this is coming. If you look at the lung cancer story, initially it was for all comers in second line, then we found out in the first line it doesn't really work. Even in the neoadjuvant lung setting, we are giving it for everyone. But my belief is, and the HR is 0.89, it doesn't really work in PDL1 less than 1. We need to go somewhere else to really make sure that it works. So from the learning point which came from this ASCO was that I will be doing PDL1 CPS. If it is less than 1, I will not do. And the research question that we can ask is, take a PDL1, do it on the pre-treatment biopsy, also do it on the post-resection specimen, see whether the PDL1 status is changing or not, because in this they have taken any PDL1 is absolutely okay, but I would be looking at the PDL1 status from now. The 5-year OS rates were higher, median OS improvements were there, but again, this trial was not powered for that, so I think approval is there for everyone, but in the practice, I would want to give it for PDL1 CPS more than 1, and that is what I would probably do. So, but that was not that was a different part. Now the fun part starts. This patient received 6 cycles of immunotherapy. Her PDL CPS1 score was 10. Fantastic. After 6 cycles of treatment, this patient had we got a PET scan done. So somebody who's paying out of their own pocket will want to get a PET scan done. So Abhinav, park your car for 5 more minutes. That's the one which we want to discuss. This patient had a metabolic active thickening in the gastric pulled up stomach, and we got a biopsy done, which came as squamous cell carcinoma. So now, pre-op RTCT, surgery, YPT3N2. Now this patient has a localized recurrence on immunotherapy. So Dr. Abhinav, and then Dr. Abhishek, then Dr. Talwar, and then Dr. Vaid, the final word. How will you treat this patient?
Sir,
Difficult one, but I thought we'll have fun.
No. So, sir, I think on
तुम पहले गाड़ी पार्क
immunotherapy,
कर लो. तुम पहले गाड़ी पार्क करो.
कर ली मैंने
हाँ,
गाड़ी
बस फिर अब
खड़ी कर
बताओ.
दी सर. आज बारिश इतनी हुई है, ड्राइवर नहीं आया मेरे को.
Doesn't make a difference. तो गाड़ी पहले पार्क कर.
कर ली. So, sir, so if the patient has local recurrence while on immunotherapy,
Yes.
patient has already undergone CTRT,
Correct.
undergone surgery,
Correct.
and local recurrence.
Correct.
I would involve, first of all, radiation oncologist.
Correct.
If he can give some sort of, SBRT or something
Correct.
like that. Okay. And I would put this patient on some sort of metronomic chemotherapy, because I know that this patient is going to, not make it.
Okay. So you would want to give
Because
radiotherapy and some amount of oral metronomic chemotherapy. Fantastic.
yes.
Let me go to Dr. Abhishek. Patient is a fit PS and everybody called her young at 45, okay?
I think going very aggressive in this patient where she had a very high disease burden after CTRT and surgery, good chunk was remaining, and just after 6 cycles of immunotherapy, she has had progression. I think my intent will be palliative only, sir.
Okay.
So probably only chemotherapy. I know there is no right or wrong answer.
Correct. Data free zone.
If you're giving SBRT and you're probably again pushing for a supposedly curative intent, I think it is giving false hope to the patient. Also, there can be a significant radiation toxicities because already radiation has received, is undergone surgery, so that can be a challenge.
So you would change her onto chemotherapy, no radiotherapy. Fantastic. Dr. Talwar.
Same, I think. You've given this patient CTRT. After that, you've done surgery and you still have an N2 disease, a T3 N2 disease. So this patient is as such going to do bad, especially after, the progression on immunotherapy also. So it must be having a lot of resistant clones. The only way to get out of that would be to give chemotherapy. Radiation, I feel, would be of a very marginal benefit in this case, because this would herald a systemic relapse in a very short time.
Okay. So, Dr. Vaid, we have very strong radiation oncologists in Medanta.
So, Ulas, This patient has a profound chemo resistance, profound radiation resistance, and a profound
Surgical resistance.
Immunoresistance.
it's a pan-resistant tumor and a local recurrence within 6 months of the last radiation. Am I right?
Correct, sir. Within not 6 months, yeah, 8 to 10 months, if you
8
take
months.
surgery and
8
everything.
months. So that is not much to choose between 6 and 8.
Yep.
So it's a pan-resistant tumor, and the proverbial American comment that should go for a clinical trial. And you and me don't have a clinical trial in
Correct,
this.
sir.
So that's the easiest to escape hunt for a clinical trial.
जब clinical trial होता है तो सर लोग उसमें नहीं आते हैं.
उसमें नहीं आते. ठीक है. So young patients still fit enough warrants a discussion, but we know we are headed for disaster.
Sir,
And
they have come to you for fourth opinion. One is my opinion. One is Abhishek's, Abhinav. They are very keen for a.
सो मैं तो उनको ये कहता हूँ कि आप क्या करोगे, घर जाके पर्ची डालोगे क्या एक डिब्बे में और 4 में से एक निकालोगे फिर वो करोगे आप. This is, if you read the options, NCCN would give you different boxes and then second line, third line, metronomic in certain situations and all that, which practically doesn't work. Maybe docetaxel, irinotecan, all those things, they could be discussed.
So I'll tell you what we did. Now this patient actually had taken 6 cycles of immunotherapy. She was getting free immunotherapy. So with the PAP program which was there, she said, "Sir, अगर एक आध और ले लूंगा तो जो खर्चा है कम से कम free मिल जाएगा." We spoke to the radiation oncologist and we agreed. The medical oncologist agreed that radiation won't work. So what we did was we gave this patient immunotherapy and Folfox. She had taken Paclitaxel, but she didn't really respond and had a progression on that, and that basically echoes what everybody had said, that she really won't well. Typically, what I have seen is immunotherapy, continuing immunotherapy beyond progression doesn't really work. That's what I have seen. But it's very difficult, and especially in the PAP that we have, that if you give 5, remaining is free. So, a lot of times there's a lot of pressure from the patient side that, okay, fine, let's give it. But typically what I've seen, it doesn't really work. So, Abhishek, now I thought that was a stage 4 one. We just had fun. So let's have some stage 4 discussion also. Are you convinced, Abhishek, regarding the role of immunotherapy in CA esophagus? Do you think it's a CA lung with PDL1 more than 50%? Or do you think it's a melanoma? Or do you think it's a CA breast? Somewhere it may act or something. Or it's PDL1 less than 1 of lung? Where do you think you will place it as?
It is esophagus, sir. It is not melanoma or breast. So yeah, I don't think there is a lot of role for single agent immunotherapy, even if the data for that is there in second line, as Dr. Talwar had also mentioned in his slide. But clinically the benefit is not that great. So I think chemo still plays a major role, and whatever data is available for pembrolizumab or nivolumab or more recently tislelizumab, of course, it is in combination with chemotherapy. So yes, for high PDL1 score, like we have data for CPS more than 10, we have data for CPS more than 1. The data is there to give immunotherapy in combination with chemo.
Correct.
But what has been
your... I mean, are you like, you really have to convince yourself or persuade yourself for this?
Yes, I do. I would say that the benefit is not as marked as we see it in RCCs or lung or melanomas.
But it's a good choice to have, actually.
Good choice to have, yeah. Because if you're going to use it rather upfront rather than keeping it reserved for second line.
So Abhinav, when you give any, right now we had immunotherapy, which is the regimen that you give it along with?
Sir, for I think for squamous, I would go with IO plus Paclitaxel. But for adeno,
no, we'll talk about squamous only. So you go into Paclitaxel, and how do you
Paclitaxel or cisplatin 5-FU?
Dr. Vaid wants to make a point. Dr. Vaid.
So Ullas, a couple of things which are very clear about the data of immunotherapy in stage 4 or advanced. And we are talking about de novo, untreated patients.
Yes, sir.
So Pembro and Nivo don't work. They are detrimental in certain types of situations, and already they have self-withdrawn these indications, these approvals. So the only two drugs, two IOs which work, one is Tisle and the other is toripalimab. Toripalimab has a European label, and toripalimab works across PDL1, no matter what is the expression. And Tisle, we have seen the data, it works beyond 5-10%. And you can increase the median overall survival from 10 to 11 months to 17 18 months, 17 months with both the drugs. So there isn't much to choose between these two drugs. However, the debate about the chemo backbone would always remain, because the three of them, Nivo, Pembro, and Tisle, they used fluoropyrimidine's platinum. Only, there is data for toripalimab with paclitaxel, but in the Indian setting, realize that you call the patient once in 3 weeks or maximum day 1, day 8. Don't need a central line, don't need infusion, don't need those 3-4 days, and you wonder, should I give it for 3 days or 4 days? The nutritional status, all these patients are already, they have lost enough of their muscle mass and all that. So taxane platinum with an IO, I think it's a clear choice, and you can increase the median overall survival from 10-11 months to 17 months.
And with some 10 to 15% people having a long-term survival also sometime,
Yes.
maybe beyond of, that's the same tail of the tail curve.
Yes.
Okay. Abhishek, PDL1, believer in esophagus or not believer?
So with whatever data we have been using in with respect to Nivo and Pembro, yes, we have been using PDL1 to decide whether we want to use immuno or not. As Vatser said, that there are certain subset of patients where it can be actually detrimental, particularly PDL1 less than 1%. With this Lilly data, we have seen that irrespective of PDL1, the data is there with where it can lead to improved outcomes.
Okay. Dr. Vineet, last question, and I will finish this off. Do you think various IO agents, Tori, Tisli, Nivo, Pembro, they are similar or they are same but different?
I think Dr. Ved has given a bang-on answer as far as the squamous esophagus is concerned. I would go the same.
Okay. So this is what I saw from there. I think PDL1 doing is very, very important. I would absolutely do a PDL1, and this is an old data from 2024 by the time Tori Tisle was not there. But I think PDL1 is something which I would love to do. If it is more than 1, CPS more than 1 or 10, I would want to really go ahead and give them immunotherapy plus this. To me, definitely by and large, I mean, they're same, but there are slight differences. Taxane platinum remains a good backbone, and a good fit patient, a Folfox or a 5-FU cisplatin also can be used. And I do think if the cost is all right, immunotherapy should be offered to all the patients in metastatic CA esophagus, because that remains your only chance of having a long-term survival. We also had a case of CA lung, but I think I've overshot my time. And with this, I would want to say thank you. And I would like to go and say, this is my favorite slide last. That is why medicine is the science of uncertainty and art of probability. If it was not for that, everybody in America and ChatGPT would have been a doctor. And the second one is, the greater the crisis, the more significant the opportunity. So I think esophagus is a good thing to do research and clinical trials and then get some good data on. With this, thank you. Thank you, Dr. Ved, for getting the invite. Thank you.
Thank you, everyone on the program. And ladies and gentlemen, we would agree that we have had a remarkable session on tislelizumab, both in lung cancer as well as esophageal cancer. And I'm really grateful to everyone who has energized this effort, and great presentations by Sumant and Vineet, and as usual, great moderation. Ulas, you bring so much into it that it lights up, and your last slide, that discussing science is one part, but discussing the art of it, you bring that art component to it. Thank you so
Learning
much.
from you, sir.
As always. There was a comment about the efficacy of these drugs. Now, the Tisle has a very innovative. This is an innovative anti-PD1, And there is a very minimal binding of the FC gamma region on the receptors on the macrophages, and so there is a better penetration as well as a dissolution of the drug. So there is something unique about the structure of this drug which lends it the potency as well. And uh, also this avoids this also aids the body's immune system in detecting and fighting the tumor cells much better. And with that, we come to the conclusion end of this these discussions. And you've seen the sponsors. One can show that slide once again, and we have to thank the sponsors of this very interesting meeting. And Anshika, could you show that again? There was a briefly put up out there. This is Glenmark principally, Guardant, and Ori. They have brought this program to fruition today. And thanks to Mice Ideas, Rajesh, I can see you on the screen, and all your team, Anshika, Arundhati, everyone, and Tirth as well. And all the participants who were on the program, we had more than 100 registrations, and I hope everybody's joined and everybody's enjoyed the program. Thank you so much. Back to Rajesh for your comments about it.
Thank you very much, sir. We had a good meeting today. Thank you, sir.
Thank you, sir.
Thank you.